So thank you very much. I am almost certain that most of you said is not true. I am a very simple physician from my country. Most of the time I treat patients. I only treat children from 0 to 35 years. My wife objects because she believes that also men at 50 are children. But I think at 35 they should behave as adult people, so we transfer them to the adults willy-nilly, so they want it or not. First, I want to say my sincere thanks to Christos, to Professor Bartzokas. You may not know, but he organized an international conference in 1993 on a boat. And this boat was cruising your beautiful Aegean Sea. And you know what? I don't remember much of the meeting, but I do remember the islands and the beautiful sea. And since then, we are sailing these islands every year. So I'm quite a familiar face in Greece. So thank you very much for having me here. And the third thing I want to say is that I'm so impressed with this beautiful hospital. Actually, we have to make sure we come close to this standard, actually, in my country. So I'm extremely impressed with the work that Christos is doing here. This is our hospital. This hospital actually is a children's hospital that also takes care of children only with neurosurgery, cardiosurgery, an ICU unit that is currently actually the only completely computerized ICU unit in the region of 1,000 kilometers. It's a paperless hospital, and most of the also things that I will talk to you about now actually is linked to the single computer system. We still have papers because nobody believes actually this will work. We are waiting every day that it breaks down. And there are even bets, you know, in the hospital. Many people put good wine on it that this system will break. But so far, it's somehow working. Our department is here, so I can see mountains from my window, which is nice. What I will share with you tonight is a little bit on the use of pumps and sensors on the metabolic control, on the hypoglycemia, a little bit then about the routine use that we have, and some perspective. First, I want to tell you that in my country, actually, diabetes type 1 is rising. This is a paper in Lancet, and here you see Slovenia, this country, this small dot here. It's almost as big as Athens, I would say. And the curious thing is, this is Central Europe here, that the increase is highest in the population below age of 5. And here, actually, below age of 5, we have a 15% annual rise in the last 10 years, which means that we double the population of these patients every 7 years. I don't have to tell you, it's a huge burden, actually. You know, this year alone, we had almost 40 new children below the age of 7 with type 1 diabetes. And they tend to stay with us, so the patient population keeps growing and growing. And I was very impressed with this study actually from Hormones. It's a Greek journal, and I'm sorry I cannot show you the authors, but the senior author is who else than Professor Batzokas. And what's interesting, it was published, I think, a couple of months ago in this journal, and what is interesting is that the difference, this is the seasonal variability which is seen all over the world in children with diabetes, is not seen in the population below 3 years. So it seems to be another evidence that these small children may have a different type of diabetes as compared to older children. I'm very glad for this additional piece of evidence coming from this very center. All right. Yeah. So the first, obviously, who published a pump in a patient was John Pickup. He published this in Lancet in 1979. I'm sorry, yes, in 1979. And he was also the first to do a meta-analysis. So this is a meta-analysis from John Pickup. He nicely separated all studies that included MDI with the regular insulins, and here all studies that used glargine. And as you can see, pump was on average superior for 0.6% in glycosylated hemoglobin as compared to MDI. And then if you want, this is a very, obviously John is a pro-pump person. But if you want to see a study from an enemy of pumps, then you go to the Mayo study. This is the study from the Mayo Clinic published in JCM in 2009. And they only included, in the end, 8 trials, actually, because only 8 were deemed to be good enough. And despite their best effort, actually, despite their best effort here, it was still significant, with a smaller decrease of 0.2, but still a significant difference in between pumps and MDI with Lantus, despite the best effort, actually, to destroy this difference. And finally, if you want to see the Cochrane database analysis, actually, even here you have a 0.25% difference that favors pump, and obviously this is statistically significant. If you go into crossover trials as well as parallel trials, almost the same difference in A1C, as you can see, and it is, of course, highly statistically significant. So the quest about whether the pumps do significantly decrease A1C or not is closed in Europe. It was closed in the United States before, and this is also why almost every insurance system in Europe is now reimbursing pumps freely. As you know, in my country, as you prescribe an insulin, you prescribe an insulin pump, and the insurance system covers all expenses because the evidence is so strong it would be illegal not to give a pump to a patient with type 1 diabetes. Interestingly, of course, now we are interested in children, as we said, and the question was, do we have evidence for children? Well, the Cochrane database actually did investigate this in less than 18 years of age. It was as significant here, actually, as significant as with the adult population. Both values were below 0.05. How's about hypoglycemia? Some people say, well, with the pumps you have a significant decrease in A1C. This is true, but is it clinically meaningful? And if you're not sure, actually, then you go to hypoglycemia part of it. And this is, again, the John Pickup study. And as you can see here, the hypoglycemia decrease is 4 times, so 400%. No question about the clinical significance there. If you go to the very stringent study of the Mayo Clinic, so the one that hate pumps actually, what they saw is it was a 100% reduction, so by 50 down in severe hypoglycemia. So even these people actually acknowledged that if anything, pumps are extremely successful in reducing hypoglycemia. And finally, we have a meta-analysis for children. So Eva from Poland put all these small trials that were done in pediatrics together, and all these 5 trials together only had 68 patients in control and 68 in the pump treatment, but the significance was very significant. So here you have the significance, and again a decrease of 0.24%. So yes, also for pediatric population, we now have an ADA grade A evidence, which means several randomized controlled trials with a meta-analysis that show a significant decrease in glycosylated hemoglobin in childhood. And what's nice is that these patients that have the worst control actually would benefit more. So here, if your patient is above 10 with glycosylated hemoglobin, the expected drop may be about 1.8%, which of course has a very nice clinical meaning. Another study, I believe, is a very nice study, and this study investigated the initialization of pump from the disease onset, from the very beginning of the disease. This is a French study, a collaborative French study, and here you see this is the duration of diabetes in years, so it was an 8-year observational study, a prospective one. And here you have the MDI, multiple daily injections, and here you have the pump patients. As you can see, the whole 8 years, pump patients did significantly better than patients on the MDI. What's more, actually, they had one group that they switched after 2 years. They switched them from MDI to the pumps. And as you can see, they nicely went from the curve of the MDI down to the curve of pumps and stay with pumps thereafter. So it seems to be a very nice prospective proof that the use of pumps in children from the very beginning of the disease makes a lot of sense because of the improved control over an 8-year period. And of course, in my center, anybody that has an age below 7 immediately starts with an insulin pump. We don't start with injections at all. How's about hypoglycemia in children? Well, what's interesting is that here, this is the Australian data. And look, Australians did a very nice job in decreasing glycosylated hemoglobin over the years. This is the beginning of this DCCT, this is 2002. However, the incidence of severe hypoglycemia increased and stayed rather high, so they couldn't decrease it anymore. Whereas in pump studies in children, this is a very nice study from Germany, actually, you can show a very nice decrease, a significant decrease, obviously, in hypoglycemia rate immediately after the introduction of pumps. And is this important? I want to draw your attention. This was published actually 3 months ago, and it's a study of brain of children. And this is actually the year, so 4, 5, 6, 7, 8, this is the healthy population. And as you know, the myelinization of brain actually goes on until the age of 8 or 9. And the white matter should increase with time, which is depicted here. However, in children with poorly controlled diabetes, this doesn't occur. If anything, the white matter diminishes, which is probably the first direct evidence. We know that they have cognitive impairment, but we didn't know that you can see this with MRI. And this is probably the first direct evidence that poor control in children actually does impair neuronal development and does directly affect cognitive impairment. So we do need to do a better job. We do need to use anything available to treat these children better. This is just a corroboration of a previous study. This is a hippocampal region that was measured by MRI automatically. And here the hippocampal region was actually significantly associated with severe hypoglycemia. They speculate that the more severe hypoglycemia, the higher was the hippocampal region. They actually claim it was gliosis that caused this. Because of hypoglycemia, the gliosis developed, which is an interesting concept actually, and just another direct proof that poor diabetes control, in this case hypoglycemia, directly damage childhood brain. Well, you know, why can we do better in children? Well, there is some explanation to it. This, again, is a German study of more than 1,000 patients, and they computerized basal rates and realized that basal rates differ with age. If this is a typical 2-peak basal rate of a young adult, one peak for the dawn phenomenon, the other peak for the dusk phenomenon, here we see a typical basal rate of a child below age of 5. Don't ask me why children below age of 5 need most insulin around midnight. I don't know. And I don't know anybody that can explain this, but they do. Most people that treat small children actually can tell you this phenomenon. And of course, with the pump, you can nicely mimic this, so you adjust the basal rate according to the age and the need of your patient. And this is how you improve A1C, and this is how you reduce hypoglycemia. Furthermore, if by adjusting boluses, actually, the study comes from Fergus, from Australia, from Melbourne, actually, again, you can significantly improve the postprandial profile if you have a high glucose index meal by computerizing long boluses. So again, with this technology, with the use of a dual bolus, actually, you can considerably better manage postprandial with a high glycemic index food.